Hello, and thank you for joining us. We are going to give a moment for folks to get fully dialed in and connected, and then we will dive right into our presentation today. So just one moment and we will get started. Looks like that is everyone in the waiting room. All right, so I'm sure we'll have more folks joining us as we go, but as we do have a pretty packed agenda, we want to go ahead and get started. So thank you for joining us. We are Comagine Health, working in partnership with the Geriatric Workforce Enhancement Program and the Utah Geriatric Education Consortium. And today we are here to talk about an updated report from the Kem C Gardner Policy Institute that Natalie will be presenting on behalf of the Policy Institute. And then we will have a discussion with Savannah, our Health Equity Program Manager at Comagine Health, about how that information can be incorporated in the work we do within the lens of health equity. So just a couple housekeeping comments before we get started. This is a rather informal presentation. We have some PowerPoint presentations that our speakers will be sharing today. We will make those slides available to you. But we also, if you have questions throughout the presentation, please feel free to put those into chat or unmute and ask your question. And we will save some time after Natalie and after Savannah's presentations for questions. But if you are like me and they kind of come into your mind as you think of them, please feel free to put that in the chat and we will make sure that we address those questions. And then we are approved today for one social work continuing education credit. So we appreciate you being here and receiving that credit. And thank you on behalf of the Utah Social Work Association for their help in sponsoring this as well. So in order to receive your credit, please, you need to be on for the entire duration of the session today. And then at the end, we will have a quick evaluation survey for you to complete. And that will be where you will put your information in order to obtain your CEU certification. So without further ado, I would like to turn the time over to Natalie. She is the Associate Dean and Director of the Kem C Gardner Policy Institute at the David Eccles School of Business. And we are incredibly grateful to have her with us today to share some really exciting information and just to hear from the updates from the Policy Institute. So thank you, Natalie, and please go ahead.
Yeah, thanks so much, Adrienne. Great to join Comagine for this webinar. Thanks for the invitation to be here. I'm going to share information that we're finding is very helpful and useful along the lines of something we're calling the new Utah. And imagine at the Gardner Institute that we see all this work on all this data and trends on the economy, on demographics, on public policy issues. And every once in a while, things start to pop and emerge where you're like, wow, this is new, this is different. And we're coining the term, the new Utah, for something that I think is pretty dramatic happening in our state. And I do think of this as very much as COVID has wound down and we've sort of entered this new chapter, that something's different in Utah. And I'm going to walk you through that evidence. At the Gardner Institute, we often do these Utah Economist covers. So the Economist magazine's the most important economic periodical in the English-speaking world, and we have fun with it and make our own Utah Economist and do Economist covers. And you can see we're leading here with an Economist cover that shows someone leaving the past, a monocultural state, an internal growth state, a younger state, a smaller state, and walking to what is in the future, what's new. And we highlight what some of those are. The changes I'm talking about is this shift from a small state to a mid-sized state. I'll walk through these in more detail. An internal growth state to an external growth state, a monocultural state to a multicultural state, a young state that becomes older, and a state that has a strong economy but has transitioned to an absolutely elite economy, which is a word we don't use lightly. So this is what we're framing as the new Utah, these 5 dimensions. And I just want to walk through each of them briefly. As a mid-sized state, so between the 2010 census and the 2020 census, Utah jumped 4 states in order, so that we are now the 30th largest state in population size. It's a pretty, for people that have spent a lot of time here, we are a, interior Western state. We're a Rocky Mountain state, but for most of the lifespans of people in leadership positions in our state right now, we've been a 36th, 35th, 34th largest state. We've jumped to 30th. And if you take all 50 states plus the District of Columbia and divide it into 3 and have the large states, the medium size, and the small, we've now entered into that mid-tier size. And that does all sorts of things, right? It means you have more direct flights. It means you have professional sports franchises looking at you. It also means that you have more congestion. You have some challenges we haven't had in the past. So that's part of the new Utah. External growth is another really interesting one. The rule of thumb in our state is that 2/3 of our growth comes from ourselves, births in excess of deaths. And that's really been our past. For the last 2 years, that has changed, and we've had 61% of our growth from in-migration. And it's actually quite a story to look at net in-migration to our state. This is going all the way back to the 1950s, but in and out, in and out, in and out. 70s was an energy decade, a lot of in-migration. 80s, a lot of out-migration, 7 consecutive years. We've now had 31 of 32 years of net in-migration. And you can see the popping in these last 2 years. And when you combine that with a declining fertility rate, it means that a higher proportion of our growth is coming from new migrants. And so 2 years maybe doesn't a trend make, but we don't see this fertility rate drop turning around anytime soon. And we also have an elite economy that is bringing people to our state. And so that's a state that's changing. I won't spend a ton of time on the older population. I know this is a healthcare audience, and that's something that healthcare tracks and understands really closely. But within our planning horizon, Utah moves from 1 in 10 being 65 and older to 1 in 5. Dramatic, right? That changes the structure of your economy. It changes your transportation system. It changes what kind of housing you build, changes the healthcare sector dramatically. You can look at it in more detail in a population pyramid like this. This pyramid shows males on the left, females on the right. The internal dark sort of Christmas tree looking thing is Utah in 2020, and those outer shadows are Utah in 2060. But you see how we go from what I'll call a Christmas tree to more of a pine cone. And you can also see age waves, right? Birth waves, if you want. You can see, I'll just make note here, you can see the LDS missionaries at the 18, 19, 20-year-old, and just give you that orientation. Each of these lines is an age, all the way up to 100 plus where it's top coded. But you can see we become a larger state and we become an older state. Multicultural, 1 in 4 Utahns are now racially ethnic diversity. And our projections are that that will continue to grow. And over the planning horizon, we'll move to, instead of it being 1 in 4, it'll be 1 in 3. And then finally, on the point, I've got more, but on the dimensions of the new Utah is this idea of being an elite economy. And I'm going to show you a really complex graphic to make that point. But if you'll look at this, this came from, I should actually reference here, this came from the Governor's Office of Planning and Budget. They do terrific work. And this actually shows monthly job growth for all 50 states and since 2000. So all of these gray lines are some other state than Utah. The black is the US average and the red is Utah. And what I want you to do, and these shaded areas are recessions, but I want you to look at 2000 to 2010 and look at the red line and see how it's about the national average, sometimes above, does a lot better than the national average through here. Then the Great Recession hits, it actually hits Utah harder than the nation. But I would call this a strong economy. Now you go to 2011 or so and look forward, and I want you to see how that red line is truly elite in terms of outperforming other states. Very durable, very consistent, a job growth that was steady. North Dakota had a higher growth rate here, but it declined here, right? This is boom and bust of a mining or energy economy. Utah, very diverse economy, growing economy. The pandemic recession hits, the nation drops to here. Some states drop to here. Look where Utah is. And for a healthcare audience, just to remember that if we look at the cumulative case fatality rate from COVID, as of November 8th, 2022, just picking a time, when did COVID kind of unwind and whatnot. But we had the third best performance by this macro measure among states. And then if we look at an economic measure, so jobs pre-COVID, February 2020 to September 2022, second best performance of all 50 states. Really amazing to be able to do that. Just to give you a point of reference, Hawaii did really well here, an island, you'd expect that, but on job growth, it was the worst. Of course, it's a tourism dependent economy, but that's part of the point, is that the structure of our economy made it so that did not happen. So that's elite economy. Now, just to move so I can get to some questions, another economist cover is to say that this new Utah brings lots of benefits. You can see I've got NHL hockey, MLB baseball. I've got, Delta Hub, and they signed their expansion, a new airport, and their commitment to our city. I mean, lots of great things come from it, but you also have the new Utah costs, and we're just, what's happened in housing is a true cost to our economy and to our state. This is the red snake for those of you that are skiers or recreators up Little Cottonwood Canyon. So that's congestion point. And pollution, we could also put Great Salt Lake here, but just some of the environmental challenges that come with the type of growth. So you get these strategic questions: how do we grow and maintain the distinctive features we value? And how do we help all Utahns to thrive? And so, yeah, the things we value: life quality in our canyons. Here's arguably the best measure of life quality is how long do you live? This is life expectancy in Salt Lake County by neighborhood, and just highlighting Foothill as the longest life expectancy, and South Salt Lake and Kearns as having two of the lowest life expectancies. But look at the spread, right? I don't think any of us can feel good about that. On the point of not leaving people behind, very prosperous state, but we have, I'm particularly focused on these two, Carbon and Emery County, these coal region of our state, that is actually contracting, getting smaller. The economy gets smaller over this time period. Or how about as a state that is diversifying rapidly to show student achievement by race, ethnicity, these significant disparities. On the left, English language arts proficiency, grades 3 through 8, math proficiency 3 through 8, English language arts, grade 9 through 10, math 9 through 10, and then graduation rates. Or how about percent change in average apartment rent and median income? So the red is the rent change and the black's the income change. Utah County looks okay, but look at these other large metro counties, how income's not keeping pace with rent and the squeeze that puts. Evictions now rising. So during COVID, a lot of assistance that brought evictions down, but now they're up and rising. Or just the sales price of a home and monthly mortgage payments. This is to make the point that the sales prices are dropping, but the monthly mortgage payments are still on the rise because of rising interest rates. So I only have 4 more slides, but the question is, that's the new Utah. That's the evidence to support it. And the question is, what do you do? And our counsel to decision makers is keep an open mind. Meaning be prepared to change. If Utah is changed, we have to change. Be prepared to listen more, because you've got a different population with different needs. And part of having an open mind is being willing to listen to different voices and enlarge perspective. We think that it requires us to invest even more. And so the idea is we want to preserve the things we value. We want to preserve life quality. And that requires that we invest. I'll give you an example. Kimball Junction in Park City. It gets really congested. We can invest and help improve that if we're willing to spend more money in transportation improvements in that area, for example. And then finally, the notion of unifying and dignifying. If all we do is spit at each other and throw bombs at each other, we're not going to be able to preserve the things we value and make sure everybody benefits. We have to unify and dignify in the way we conduct ourselves. Well, that's the message I wanted to share with you today. And maybe I can just open it up now, and happy to take questions. Certainly there's a lot that is left unsaid in that, but at least it is a teaser. And so with your permission, Adrian, I'll just open it up and people can unmute or enter something in the chat box, and happy to respond to questions.
Yeah, absolutely. I'm not seeing any questions in the chat right now, but also folks, please feel free to unmute and ask your questions. I have a question. Maybe I can start the ball here. But I've heard a little bit about how well Utah did regarding COVID, and it was interesting, and anecdotally, but it was interesting seeing on your slide the case fatality rates specifically, calculated out. And I'm wondering, and this might be kind of outside of your scope, but are there any factors that you know of that maybe contributed to that? Is it because we're a younger, more healthier state in that time point, or our systems were deployed differently? Just wondering if you have any insights to kind of why we came out like that. I think it's great news, but it's a little bit surprising.
Yeah, I think, Adrian, I think the history of this is still being written, and our understanding of it. And boy, the social scientists are making their assessments and whatnot. I will make a few observations. Absolutely, a young state helped us. Absolutely. Another comment would be that this is a state with a lot of social capital, meaning that we have networks of trust, and we still come together and we still work to prevent and solve problems. We're not perfect. We had a lot of challenges during COVID. Mike Levitt was a mentor to me, former secretary, obviously, of Health and Human Services, knew a lot about pandemics. He said to me one time, nobody looks good during a pandemic. And I think that's, a fair assessment. But I do think our state leadership did a really terrific job. And I'll point to Governor Herbert, for instance, who you can argue about when, the pandemic really became evident, but let's go to around March 13th, March 18th of 2020. By March 24th, Governor Herbert had an economic plan published called Utah Leads Together. And that plan went through 5 more iterations. And that's Utah, right? A terrifically challenging event, and a governor that brings people together, and within weeks has the first comprehensive plan for how to work through COVID out. And that plan, by the way, is on our website. You can find it. Just look for Utah Leads Together. And, it had all sorts of problems. It didn't get it right. But the point was made, we don't have to be perfect. We just have to have a plan and begin iterating in the right direction. And if it's directionally correct, it will help us. And it was directionally correct, and it did help us. So there's all sorts of, challenges, I think, but I do believe our leadership, and I give a ton of credit to our healthcare sector and the, competencies we have there. Just some thoughts. Yeah.
Yeah, thank you. That makes a lot of sense. And I mean, even our Dr. Michelle Hoffman and some of the leadership that we've had are, national and very, really kind of led the way in certain areas. So that's great to hear. Thank you.
Yeah. Does anyone else have a thought or a question or something? Yeah, please go ahead and share it, Josephine.
Yeah, go ahead and unmute, Josie. I think you're still on mute.
What a fascinating look at our state. Thank you so much.
Yeah,
Now,
pleasure.
one of the things you mentioned was pollution, air quality, and so forth. And that is directly proportional to the amount of traffic, I think. And I live out in Harriman. We are absolutely being built in and around and up out here. And we have the same street to exit that I used 20 years ago when I moved here. So how is that not going to impact in whether people think that the fact that they can't get to work in under an hour and a half or get home in the afternoon when we're so congested, that they will actually then decide maybe it would be better to move to another state that is not so congested? I see this as and maybe you can't answer this question, but I mean, I just see this as a serious point, as we have thousands of townhouses, which you think have 2 cars at least in each one, going up out here. And it is going to be an appalling situation.
Yeah, you make a really valid point. And I guess the way I would respond is that's part of where we say invest even more, that we're not keeping up. Another point I would make is that there's no question that this will be a dominant challenge for our state moving forward. Part of the new Utah is recognizing that we can't keep doing things the way we've done them in the past because we've entered a new chapter. And what does that mean when it comes to urban planning and transportation investment? I think it means a lot of things. I think it means that we're going to have more people work closer to where they live. I think it means that transit is a huge part of our future. And I will say the legislature does understand that. They've been pouring a lot of money into transit. They're right now double tracking Front Runner, which makes it so you can have more frequent headways on that important commuter rail. It means that you have to have a lot of technological innovation. And so to your point that more cars means more congestion, it does. If we have more people working from home, if we have more hybrid work environments, that makes a dramatic change in that trend. And I'll just on the congestion point, on the pollution point, I'll make that as we move to tier 3 fuels and newer automobiles, that helps. But your point is spot on that the growth pressures require serious leadership. And part of that leadership requires that we keep an open mind. So be prepared to change. It means listen more. And I would love to share a quote that we've been sharing. The head of the Tabernacle at Temple Square, Mac Wilberg, I'm going to call him a musical genius, but I've heard him say that the secret to a great choir or to singing in the choir is to listen louder than you sing. It's a really profound statement. Listen louder than you sing. And in the choir reference, it would be if you sing too loud or louder than the people around you, boy, that doesn't sound right. If you don't sing loud enough, you're not being heard and your voice is important in the choir. And if you don't harmonize, that's a problem. And so that listen louder than you sing, I think, is a really important message to all of us in our leadership spheres, because listening more is a part of how we position the new Utah. And then I mentioned investment and I mentioned unifying and dignifying. And so that, to me, I don't have a lot of luck on Capitol Hill if I tell them exactly what to do. And of course, I don't know what to do, but if I help with those contours, I think it helps. And that's at the Gardner Institute, we try to shed light.
Right. This is fascinating. Thank you so much.
Yeah, thanks for your comment. It makes me want to go take a drive out to your neighborhood, which I'm going to add to my list.
Please do. At 5 o'clock.
Okay.
I feel like every time I drive out west, I don't recognize it. It's just changing so rapidly.
Yeah,
So
they say that as you fly into the approach to Salt Lake International these days and you come over Utah County, that you almost see as many lights west of Utah Lake as east of Utah Lake. So that's a pretty telling comment.
Yeah, absolutely. Any other questions for Natalie? Okay, well, if you think of something, we can always send that over to Natalie in the meantime. But otherwise, thank you so much for your time today. We really appreciate, I mean, we are just fortunate to have the Policy Institute in our state and the work that you do. But really, thank you for your time and coming to share this with us. And really interesting, and will give us a lot more food for thought to continue to ponder and consider as our work goes forward. So thank you so much. I really appreciate it.
My pleasure. Thanks, everybody, and have a great rest of the day.
Thank you.
Take care. Bye-bye.
And so now we're going to turn the time over. We have another presentation with Savannah Smith, who is the Health Equity Program Manager here in Utah. And she's going to talk a little bit about, now that we've heard some of this information and gotten some kind of updated information about what our state looks like, how can we consider health equity in our work as we go forward? So I will go ahead and turn the time over to Savannah, and let me get your slides shared here just a moment.
Thanks, Adrian. Yeah, I think that set the stage, I think, for me really well. And I want to go into the next portion of this session and really hone in on when Natalie had mentioned, 1 in 4 Utahns will be racially diverse, and then that's soon going to turn to 1 in 3. So how does this impact your work in patient care and working with the aging population and providing culturally competent care? And I really loved how she said, be prepared to listen more. And I think also another point I want to say is, over time, how Utah as a state has evolved and how we have continued to evolve. I really love this quote I heard. I've been in a conference for the Center for Medicaid and Medicare Services on health equity the past 2 days, and a leadership member mentioned today, we've come too far to fail. And I think that really kind of, I don't know, it stuck with me really well, and especially thinking about, Utah and aging. And Josephine, when you said you live in Harriman, and you have one kind of like in and out. I live in Logan, and we have one main road. Main Street is like the main mode of transportation. It's like, come on, let's continue to evolve. Let's listen more. So thanks for pointing that out. So I'll dive into kind of health equity and the new Utah, as Adrian mentioned, specifically with the aging population, providing culturally competent care, and how principles such as health literacy and literacy levels play into patient care. So before I dive in, I would love for you to chat. What is health equity? What does health equity mean to you? And what does health equity mean for an aging and a multicultural population? Feel free to chat it in. And I'm just going to pause before I dive into what is health equity to kind of set the stage before I jump into what is culturally competent care.
And I think if you're interested, you can also unmute, and we'd love to hear from you.
Yep, if you want to unmute, if you want to chat. So John mentioned everyone in the population has the same outcomes. I really just like to say health equity is really just when everyone has a fair and just opportunity to achieve their highest level of health, no matter their age, their gender, their race, their ethnicity, all of that good stuff. Everyone has access to the same healthcare services. Yeah. All right, next slide. I think it's probably just another title slide. Okay, so providing culturally competent care. So today I'm going to review how to provide culturally competent care. What does culture look like? What does health literacy look like? And how can you best evolve to provide care that is appropriate for what we're seeing, especially in Utah. We're becoming a more diverse state, and I think that's really important to consider when looking at culturally and linguistically appropriate care. Next slide. Okay. So culturally and linguistically appropriate services, you'll hear me mention class standards. So focusing on providing culturally and linguistically appropriate services is a way to improve the quality of services provided to all individuals, which will ultimately help reduce health disparities and achieve health equity. The national class standards are a set of guidelines essentially created by Health and Human Services with the intention to, again, advance health equity, reduce disparities, and improve the quality of healthcare provided. So they essentially serve as a blueprint for healthcare organizations and individuals to implement culturally and linguistically appropriate services. Class is truly about being respectful and responsive to health beliefs, practices, and needs of diverse patients. And as I mentioned before, health equity, that's kind of why I wanted to bring up the definition. So the pursuit of health equity, so that pursuit of providing care and ensuring that all individuals have the same and fair opportunities to healthcare, must remain at the forefront of our efforts, especially I think within Utah. This can resonate as we grow and expand as a state and as we become more diverse. And so we must always remember that dignity and quality of care are the rights of all and not privileges of a few. Next slide. Again, so what is class? It is one strategy to help eliminate health inequities, improve quality of care, and to really just focus on two components of class. So as a provider, as a healthcare provider, no matter your setting, practicing cultural competency and cultural humility is key when providing class. And I'm just going to drop in the chat. I'm not going to review all the ins and outs of class today. There are many standards that can get really intense. So I challenge you to dive into the website from Think Cultural Health. It's a Health and Human Services website on class standards. But just to highlight cultural competency and cultural humility. So cultural competency refers to the process in which one or us, we gain the knowledge, awareness, and skills to work and communicate effectively in cross-cultural situations. And cultural humility refers to the process of truly understanding your biases and privileges, managing power imbalances, and maintaining a stance that is open and responsive to others in relation to their cultural identity and aspects that are most important to them as a person. Next slide. So what does providing class accomplish? Providing class does all of these things that you see in this little graphic. It can help improve the quality of care when you're working with patients and you are thinking about the demographic challenges, or not challenges, you're thinking about the demographic changes. You're being responsive to the varying demographics of people. It can help influence legislation and policies around care and healthcare. It can reduce litigation. It can improve access to care, and it can really, in one way, shape, or form, it can truly improve how you communicate with patients, how you follow up with patients, and improve the health outcomes of the populations in which you may be working with or serve. Next slide. So again, the purpose to advance health equity, improve quality of care, and help eliminate disparities. That's the main mission and the purpose. Next slide. Yeah, sorry. I talk a lot, I talk fast. So the national class standards, as I mentioned, are pretty lengthy. There's a set of 15 standards. Those 15 standards are outlined within the link that I have given you. But the main focus and the principal standard is to provide effective, equitable, understandable, and respectful quality of care that are truly responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. So thinking of other communication needs as sign language or Braille, or when you're working with hard of hearing patients. So the remaining standards are then divided into 3 themes. So we have governance, leadership, and workforce. Those are standards 2 to 4. Communication and language assistance are standards 5 to 8. And engagement, continuous improvement, and accountability are standards 9 to 15. And so just as a quick kind of heads up, if you do navigate the Think Cultural Health website, you'll see all of those standards written out. And those are, again, the set of guidelines that you as an organization, as a provider, as a person who is providing care to the aging population or patients from multicultural backgrounds, just things to think about. And once standards 2 through 15 are met, then that principal standard has essentially truly been met. Again, the standards are long and lengthy. I work with organizations who just want to focus on standard 5. So starting small, starting slow. I really think I like to focus on communication and language assistance first, because I think it can really translate into how you provide care, whether that be providing interpreters, providing easy to understand like print materials in facilities or within the healthcare sector system that you work in. So just a caveat there. Next slide. Okay, so now that we've reviewed class standards, and I know it was pretty quick overview, I want to highlight how to provide culturally competent care to patients and a few strategies, especially as we think about, as we grow as a state, when we start to see patients who do come from varying cultural backgrounds, how does this impact the care that I am giving? And how do my patients receive the care I'm giving? So next slide. So culture, language, and health literacy. How do these intersect? What is health literacy? And why is it important to use techniques such as plain language and the teach back method when working with patients from different backgrounds, different literacy levels, etc. So what is health literacy? Health literacy is essentially the degree to which we obtain and process and understand basic information and services necessary to make appropriate health decisions. So how do we understand what is going on about our health, what our doctors are saying to us, and how do we process and understand that? So the culturally bound beliefs, values, and preferences that a person holds truly do influence how someone can interpret healthcare messages and messaging and communication. So I want to make note that knowing and understanding a patient's language and culture is key for knowing how health literate the person is in each situation. So think about this. Patients who often come from minority cultural groups may be more subjected to the effects of low health literacy than patients from the dominant culture because of interactions between literacy, cross-cultural communication barriers, including language, and the experience of bias. One example, so a US-born patient with low health literacy and is diagnosed with a UTI might be able to communicate with nurses, navigate the healthcare system, and maybe manage their symptoms and severity of the UTI more effectively than, let's say, a recent refugee who also exhibits low health literacy and the same diagnosis. The native-born patient would be able to rely on English proficiency and some familiarity with the US healthcare system, whereas a refugee would lack experiences in these areas. So the ability to recognize the interactions between language, culture, and health literacy is key. Adapting your communication approaches and care plans accordingly is also important to effectively meet the patient where they're at. So meeting the individual needs of the patient. Health literacy can also incorporate reading, writing, and numeracy skills, listening and speaking skills. And so when you think about these varying skills, it's actually really important to have the use of plain language. So having writing that is clear, to the point, and it can help improve communication and takes less time to read and understand. We usually like to say, if you are providing like print materials or handouts, having it on a 5th grade reading level is key. One really great method when working with patients with limited English proficiency or literacy levels that vary is to utilize the use of the teach back method. So teach back is essentially checking the understanding of your patients by asking them to describe in their own words their plan of care. So they're teaching back to you what you just taught to them or what you have communicated, so that you're on the same page of your patient. Next slide. So some strategies as a healthcare provider, as someone who works in patient care or works directly with residents in nursing homes, for example. So you have the expertise about treating a disease or condition, but you're also charged with providing that high quality care. So learning again about the patient's social identities, cultural background, life experiences, values, and communication needs is key. So a few strategies is to be aware of all aspects of communication and understand that relationship between communication and your patient's cultural identity. Communicating information that almost anybody will be able to understand. Again, consider using the use of the teach back method. Ask all patients for their preferred language. If that language is not English, arrange for language assistance services. And when possible, utilize the LEARN model and SHARE approach. These are 2 really great models, I think. So the LEARN model is to listen with empathy, explain your perception of what is going on, acknowledge and discuss differences and similarities, recommend a treatment plan, and negotiate the final treatment plan between you and your patient. And the SHARE model is to seek participation, help your patient explore and compare options to their treatment or plan of care, assess your patient's values and preferences, reach a decision, and then evaluate your patient's decision. Next slide. So these are 2 tools. I think I'll share these 2 within the chat. So these are 2 tools to implement like culturally competent care, class standards. Again, both really great. They're lengthy, so when you have time, they're really great to read. It can be adapted to any healthcare setting, and it may be used as a guide to implement standards and provides concrete examples to put culturally competent care and class standards into practice. Next slide. You can go to the next slide. So we'll dive into just practicing cultural humility. As I mentioned in the beginning of the slide, cultural humility, again, is a reflective process of understanding your biases and privileges, maintaining a stance that is open in relation to others and aspects of their identity that is most important to them. So in practicing cultural humility and managing bias, those are 2 really great strategies to implement when you are thinking about working with patients who may come in from a different culture, who have different values than you. So a few strategies is to practice self-reflection, recognize what you don't know, and being open to learning as much as you can. Being open to others' identities, acknowledging that the resident or the patient or the individual you're working with is their own best authority, not you. Learn and grow from those who are different from you. And as we interact with diverse cultures, examine your own beliefs and prejudices. That is a tongue twister for me. So really, the superficial knowledge of cultures other than our own can truly lead to stereotyping and impact patient care, which can lead to inaccurate perceptions of the populations that you're working with. So again, challenge you to be culturally open as we grow as a state and as we see others who may appear different from us. Next slide. So becoming culturally open, I just mentioned that. What does that mean? So as we interact with diverse cultures, we must truly examine our own beliefs. Challenge yourself to cultivate a non-judgmental attitude. Inquire, ask questions. And again, having superficial knowledge of cultures other than our own can sometimes lead to stereotyping. So I got ahead of myself here, since I already said that. You go on the next slide. So your mindset is key when working with diverse patients, aging populations, et cetera, et cetera. So remember that the statistics do not apply to individuals. Information about cultures and race and ethnicity should be a guide, not a rule book. There's no strict rule that applies to one culture or another, how you interact. There are differences within cultures from generation to generation. I think no matter where you come from, you might have different beliefs than your grandma and her grandma, or your cousin and his cousin, so everything varies. And so evaluate a person using cultural clues. When you are working with patients from the same culture, they may have different cultural cues. So really get to know that person on an individual level. And then ask questions in a culturally sensitive fashion. Next slide. So becoming aware of kind of like your mindset and when you are working with multicultural, kind of the wave of multicultural in your facility, in your system, in your patient care, et cetera. So being aware of personal attitudes, belief systems, biases that may influence your interactions. These could be unconscious or unconscious biases, beliefs, or behaviors. Cultural sensitivity and cultural competence again require truly an honest assessment of our positive and negative assumptions about others. Bring these thoughts to the surface and examine them. Why are these thoughts here? How does this impact my care to my patients and who I work with on an individual level? A good way how we should interact with other cultures, again, is to act with cultural humility. So reflecting on your biases, your privileges, and maintaining that open stance. So again, bringing it back to what Natalie had mentioned, be prepared to listen more, being open, etc. So I think that concludes my presentation on culture, equity, literacy, and growing as a state. So I open up the chat to any questions, comments, or if you want to unmute yourself. I want to make sure I'm respectful of everyone's time. So I know we have about 10 minutes, but yeah.
Go ahead, Josie.
I have a question again. Do you know if you or somebody is teaching this class at the nursing school by a chance?
Ooh, the nursing school. I would assume, I would hope that it is being taught. I think, so I'm not associated with the University of Utah. I'm Comagine Health. However, I do know that at Utah State University, there are classes that are taught on biases, equity, inclusion, diversity. And I would assume at the U, there is, I would assume.
Because really the first person that you meet if you go for medical care is a nurse most often. And
Right.
and that's your first encounter with them. I work with the Salt Lake Interfaith Roundtable, so I, look at diversity of faith quite often, and there are now 11 mosques in our city and valley. So when you think about that, and usually they're very large congregations, that's a lot of people of that faith that are here, and they have obviously different biases and so forth, and needs. We have a Hindu community in South Jordan that is 400 families. That's a large number of people, that will be seeking care. We have a large Sikh group on also just outside the city. So this talk today is just perfect, because for our state, those incoming residents that we saw in the previous slide, many of them are from diverse countries and have different languages and different backgrounds. I mean, even myself coming from England, it was quite a big encounter to come here to the United States and get involved with medical care. So I can understand it's much greater when you have a different type of faith. So anyway, excellent. Thanks so much, Savannah. Go ahead.
Thank you. Yes, thank you. And a few comments from Megan. So she did confirm the University of Utah teaches in their social work program. So it's a 2-semester requirement in the MSW program. And then again, yes, across Intermountain Healthcare. So hospitals have that local diversity, equity, and inclusion committee where education surrounding my thing is cut off. Education surrounding this is going out to all hospital caregivers. Yeah, so it is a trend that we're seeing in healthcare, and I just being a part of this recent CMS Center for Medicaid and Medicare Services Health Equity Conference and the quality conferences that they hold, health equity, inclusion, really focusing on providing this culturally competent care is a huge focus. So I think hopefully we can start to see these changes across the board. And especially for smaller healthcare systems and and it's being taught more frequently at the university level, which is crucial for doctors, nurses, MAs, you name it, anyone providing patient care.
Right.
And I happen to know that the University of Utah Health System has a similar diversity and equity inclusion initiative that they're working on. And I would be surprised if the University of Utah College of Nursing didn't include this information. They are very much focused on the 4 M's of the age-friendly framework, and this is a big piece of that. So that is a main crux of their principles. But I could certainly look into that if you're curious about more specific details there. We do still have about 7 minutes left. I just want to go ahead, John, if you wouldn't mind launching the evaluation poll just so that folks can go ahead and complete that, but continue to ask your questions, put them in chat or unmute if there's anything you want to share with Savannah, or even just any thoughts you have on things that you've implemented or tools that you've utilized in this space that other folks on our call today might benefit from hearing about.
And as far as there's actually not a poll, it will be a post-event survey that will pop up following this event. So if you're looking to get the CEU, the one CEU that is available, please stay on after the event, complete the survey, and we will send out CEU certificates following this event. So thank you so much for joining today.
Thank you, John. I apologize for being mistaken. You are the expert on the Zoom process.
No problem. No problem at all.
So other questions for Savannah while we still have some time? I can say I've taken that training, the cultural linguistics training through the Department of Health and Human Services. It was about a 6-hour training program, and I learned a lot. I mean, of course, but there are sections on testing your bias. There are different scenarios where you can interact and really understand and kind of take a deep dive into some of the responses you provided. It is a really, really well put together training. And I think anyone, regardless of your level of knowledge in this space, would benefit from that training. And it's something that we've been putting more into practice with our work here at Comagine Health. So just wanted to give that plug.
And how is that obtained, Adrian?
So it's just on their website and it's for free. So I think Savannah gave us the link in chat and I can just repost that here, but it is that thinkculturalhealth.hhs. Yeah, there you go. So there's a full training there and you can receive a certification or not a certification, but a certificate that indicates that you've completed so many hours of education on this topic. This is something we're starting to require as part of our work in a lot of our different contracts, just as a foundational training and starting point to make sure that everybody is approaching their work with the same intentions.
And you do it online?
Yep, it's online, but it's interactive. So really will admit that I felt like I knew a lot coming into that training, and I learned so much from it. So and it's something that I think our teams that we're working with here internally are going to start doing on a regular basis too, because they've found that, you know, if you take that training and then you come back to it the next year, that you'll actually kind of absorb things differently and start to see maybe some of your growth, but also some of, you know, you kind of learn a lot about yourself introspectively as well. It's interesting.
Okay, good information.
So do we have any other questions for Savannah? Otherwise, we're really coming up to the end of our time and we can probably wrap it up.